Care of the Aging Adult, Unit 2, Iowa Lakes Community College, Martha Olson. We left off with this quote where we talk about why patients want to be cared about more than being cared for. As we continue and finish with Unit 2, we know that speech, there are normal changes that happen with speech. Their voice becomes shakier and breathier. You notice many of your older adults then quit reading in church or quit being on the, public speaking type of things. They make a lot of mucus, and so you might notice where they struggle with that a little bit, trying to get that expelled. Articulation changes. They decrease in respirations, causing that voice to get deeper. Changes to the larynx cause the pitch and maybe the tremulous voice as a result of that. And loss of teeth and decrease in elasticity and muscle tone causes change in some of the articulation. Many of your older adults struggle with dentures, getting them to fit, keeping them from causing them problems with their ability to eat and also to speak. Some of the pathological changes: dysarthria is a disturbed articulation caused by controlling of the speech, a disturbance in the control of speech muscles. It's related to lesions like strokes, brain tumors, degenerative diseases, some of your metabolic diseases, or toxins. Verbal apraxia is damage to the parietal lobe. Initiation, coordination, and sequencing of many of your muscle movements result causing them difficulties in executing mouth and speech movements. And with the aphasia, A is without, so without the ability to express or understand the meaning of words due to damage in the language areas of the brain. Oftentimes aphasia is due to a stroke in the left hemisphere. So lots of changes that can happen, causing problems with communication. Some of your typical speech problems are related to the dentures and the ability of the dentures to fit tightly and not cause them problems with their speech. Some of the cues that your patient might have a speech deficit: they have problem coming up with a word to express how they feel, using correct words in a sentence. They might be socially withdrawn, they isolate, they quit going to social events. They write out what they need instead of asking or verbalizing what they need. The impact of that loss of speech can be many things, including depression, social isolation, and just sitting there not asking for what they need or getting their personal needs met. They just eat what's put in front of them because they aren't communicating. With speech therapeutic communication, try to eliminate the distractions. Use short sentences that are not complicated, and then rephrase if we need to. Constant correction can be damaging to their self-esteem and can result in the punishing of the affected person's efforts. They just quit trying. With touch, some of the normal changes that we see: decreased sensitivity to warm and cold. So behind that one, you're thinking safety. They run tub water and it doesn't feel warm enough, and so they run hot water and they wind up with a scald or a burn to the skin. Reduced touch sensitivity is more prevalent in the fingertips, and so they might have trouble. Maybe you've been behind an older person in the store where they're struggling with getting the change out of their pocketbook or writing a check. Some of those types of things that you might notice. Dementia, diabetes, arthritis, and Parkinson's may exacerbate the changes in their somatosensory system. And as I said, safety is an issue, so we always think about changing positions, not leaving them with a hot water bottle or a heating pad that could cause some thermal burns. And then that postural instability, that orthostatic hypotension that we've talked about, can result as well. Some of the ideas or cues that the patient has a touch deficit: they might use their mouth to explore, they grab things too tightly, they drop things, they seem clumsy. Some of the impact for that then is impaired skin, and again the burns and pressure ulcers, because they will sit in a chair for a long time not realizing that it's uncomfortable, and the coccyx area, or the area where the pressure is to the pressure points, is causing problems for them. Some of our touch therapeutic communication that we can do, turn them often. Even if they don't have skin problems yet, we want to prevent them. Try to use other measures to comfort them. If it's, lotion on the hands and maybe a back rub or some lotion to the dry parts of their skin. And then put an extra blanket on or some socks. Those nice fleecy pajamas sometimes help keep them warm at night instead of using hot water bottles or other things that might cause problems for them. Some of the movement, normal changes, they get slower, their accuracy is not as good, and so again, we think of safety with this. Both growths and fine motor movement is affected. Pathological changes, things that we would not expect. With Parkinson's, we know the impairment of the nerves cause a lot of control, movement to the hands, the shaking of the hands, the Parkinson's shuffle. Progressive disease affecting the basal ganglia, and that is the area for movement. So we might see areas of postural or movement changes that are affected. The dopamine in that area of the basal ganglia is the neurotransmitter that is responsible for that. As far as impaired communication, it can be speech, it can be facial expression, sometimes writing. They quit writing because their hands are shaky. Their penmanship is not like it used to be. Some of the typical movement problems, then we try to consider what we can do, because they will often overestimate their ability. Family members underestimate their loved ones' abilities, and so we try to help the older adult to maintain as much of the ability as they can. In looking at some of the communication, therapeutic communication for movement, have them move as much as they can. The activities of daily living, or ADLs, are things like eating, bathing, toileting, and dressing. And we know there's a steep decline in the activities of daily living a few months prior to the death or hospitalization of an older person. And so as a nurse, we want to observe and document what they are able to do for ADLs to help get them in a placement where they will be cared for and be safe. Are they most appropriate long-term care because they can no longer bathe themselves, get to the toilet, dress themselves? If they have some of that function remaining, maybe assisted living is a better option for them. Along with ADLs, like I said, that are eating, bathing, toileting, and transferring, the IADLs, the independent activities of daily living, are more complex type of things like making meals, maintaining their finances, and taking their medications. Some of the cognitive changes that we see: fluid versus crystallized intelligence. Fluid intelligence is learning new information, and that does decline over time. Crystallized intelligence is accumulation of knowledge over their lifespan, and that typically remains stable over time. And so things that they have learned in the past, they are able to retain for them. We will be looking at dementia, delirium, and depression, and compare and contrast how they are the same and how they are different. Remember, dementia usually comes on slowly, delirium usually comes on quickly, and depression can be a result of either slow or fast, and how they are different, and the functional ability of each one. When we look at dementia, we know that they have difficulty finding words. They might substitute one word for another, and they become very easily irritated when we don't understand what they're trying to communicate to us. Try to be in a non-demanding approach, be calm, reassuring, and confident. Face the person, be at their eye level so that they don't feel vulnerable, like you're standing over them, talking down to them. Always introduce yourself. If they don't have good memory, they may not remember who you are. Your face may look familiar, but they won't remember your name. And refer to that person by their first name, or however you address them. Maybe it's Mrs. Jones, or maybe she prefers to be called Maud. Use concrete terms. Use a paired choice procedure. Would you like juice or water? So that they have two positives that they can choose from and feel like they are able to have a choice. Use open-ended questions that generate confusion. We want to avoid those type of questions. Instead of saying, "What would you like to drink?" then they can't think of, I want juice or water. Again, try to use the paired choice, would you like juice or water? Encourage them to talk about life events. And this is a possible test question when we think about how do we get them in the conversation. Things from their long-term memory that they can easily remember are a good way to start the conversation with somebody that has dementia. What were family traditions that you did every year at Christmas? Did you have a Christmas tree? Did you have oyster soup? What were the things that were important to your family? Remote memories and past events can help spark that conversation and that communication with the older adult. As we look at physiological and psychosocial barriers to communication among older adults, there are many. We want to think about how we can decrease those barriers to encourage communication and use the type of communication that is strongest and most positive for them to communicate with them. As we look at strategies, there are a lot of things we can do. We can learn to listen. Learning to listen is essential for all types of communication with all people, not just the elderly, and it's much easier to hear than it is to listen. Listening requires not only hearing what they speak in their spoken words, but also understanding what the meaning is that they're trying to say to you and the context in which the words are spoken. I can be busy and hear what somebody says to me, but to really look at them and to look at the nonverbals of facial expression. What do their eyes and their facial gestures give me so that I know that I'm really understanding that communication? And then also teach back, repeat back what has just been heard to make sure that you understand. So what I understand you saying is that, you prefer, to have, the nurse aide braid your hair every morning instead. So as we look at some of the barriers to communication, listening, speaking, sometimes gesturing, if they have had a stroke and they are not able to talk with their hands like they've been used to in the past, reading, if they're no longer able to read, that can become a barrier in their type of communication, touching and moving. As we look at some of the age-related communication changes, we want to be able to distinguish between normal and pathological. What typically normally happens in communication and in the five senses, and what is something that is abnormal, is probably a disease or a disorder that typically does not happen. And as we get into class, we will be talking about language and the meaning of words and how they've changed over time so that we can talk and visit and communicate with older adults in terms that they understand and that are meaningful and relevant for them. We may use terms like texting and cell phones and other technology words that they are not aware of, and so when we communicate with them, they're lost. So when we try to think of terms and ways that older adults might phrase things or might think of things, we have to decrease that generation barrier that might be there. A phonograph or a record player, where we might call something, an iPod. As we look at that, I always think of my nieces that were with my mom, and she often called things what she was used to, and flip-flops and some of those types of things became words that my nieces giggled a lot about because Grandma used different words than what they were used to in their generation. So our references are listed here. Overcoming the barriers, we think of ways that nurse can demonstrate caring about a person rather than caring for that person, and we'll talk about that a little more in class. Think about different types of patients we will be working with and how we communicate best with them. This is the end of Unit 2.